Hello, class. My name is Joe Crowder. I'm Director of Public Safety here at Bladen Community College, and we are going to be discussing today the roles and responsibilities and preparing you to be a preceptor. As part of the ongoing accreditation requirements for Bladen Community College, as well as some of the other surrounding education institutions, we are required to provide preceptor training for you in order to ensure that the students that are going to be going out to our clinical and field internships sites are being properly evaluated and properly coached and mentored during that time. So for the approximately next 45 minutes or so, this will be a quick review of several key areas and key components of what is expected of you as a preceptor. I want to thank you for participating in this this training opportunity, as well as I want to express my gratitude ahead of time for your continued dedication and working with the students to ensure that they are getting exactly what they need to become good clinical technicians. This course is not designed for any level of certification, so whether you're a basic EMT, advanced EMT, or paramedic, this class will be for you, and it'll be set up for any levels of training. So as we prepare for this class and we go through our objectives, we're going to talk about the definition of a preceptor. He's like, what does that mean? What does that mean to you to be a preceptor? Understanding the roles and responsibilities of a preceptor that we're expecting you to do, as well as being held accountable for. We're going to talk briefly about adult learners and how adult learners learn. That's quite different from those that are in elementary or middle school or even high school age students, and what kind of expected of adult learners. We're going to talk about learning and teaching methods briefly. Again, this class is not designed as a methodology course. This is kind of giving you an overview of what you will need to know during the time that the students will be working with you on the ambulance. We're going to talk about clinical versus field experience versus internship. I'm going to give you a brief definition of that. And then we're going to also talk about, more importantly, some of the documentation and paperwork that's kind of expected of you during their precepting time in the field. So how would you define what a preceptor is? So you kind of have to think about your experience when you were going through your training, whether it be a degree program or a certification program. Nonetheless, we were all required to ride on an ambulance to get that 24, 48 hours or even more for paramedics, obviously, to get certain skills done, to kind of learn how to function in the back of an ambulance, learn how to be a lead clinician, and then obviously to ensure that being observed and being mentored along the way to ensure that we were not detrimental or did not hurt a patient or did not hurt ourselves. So we can all think about those experiences that we had with good preceptors and with not so good preceptors, but kind of think about what that means to you. What does precepting and being a preceptor mean to you? So how may your interpretation of a preceptor differ from that of a student? So what is your idea now, being on the other side of the coin, so to speak? How does your view of being a preceptor differ from that of being a student? So what do you think your students are thinking, as well as what did you feel an adequate definition of a preceptor was while you were going through your training? Another thing to think about is, will your definition affect the learning process of the student? we have to ensure that our students are getting what they need. There was a common nomenclature, a common statement that I've heard throughout my career is that I only will release students to function independently, or new employees to function independently, if I feel comfortable that they can adequately take care of me or my family. And that's kind of a legitimate description, but it's also our responsibility to ensure that we are giving the students what they need in order to be successful. We have to give them, a somewhat nurturing environment to allow that learning to occur. If we are intimidating, or if we are rude, or if we have any of those negative behaviors um, that you can always obviously think of yourself, then sometimes it makes that learning environment very difficult. So we kind of have to think about that. So, consider what your definition is. Or am I as a preceptor, am I the stern authority figure, and they're going to do everything that I say that they're going to do, regardless, or they're not going to ride with me? Or is the definition is going to be, I'm going to be a mentor, and I'm going to help them along the way? Or am I going to be a little bit softer than that, and going to hold their hand the whole way? There's certain degrees of all of those three definitions and explanations that I just provided that are important to know when you are given the responsibility of being a preceptor. So, as we go through this few slides here, we definitely want to know and understand what it means to be a preceptor, and how we view ourselves as such. Based on this, a preceptor is an individual who enhances the student's learning experience. So we're going to stop right there for just a second. We can't make the student feel intimidated. We have to ensure that we are giving them what they need. Now, I'm not saying that we need to coddle them, and we need to ensure that let them get away with things, and not ensuring a patient's safety or the student's safety. I'm certainly not saying that, but we can't make that learning environment so strenuous and so stressful that it hampers that absorption of the material, whether it be in the back of the truck learning a 12 lead, or how to put it on a patient, or just making sure that the student has a safety vest on whenever they're functioning in the roadway. We have to ensure that we as preceptors are enhancing that experience. We're not damping it, or adversely affecting that. Also facilitates the student's transition from observer to team member to team leader, and that's ultimately kind of a big step for some people. Our accrediting body, and some of our processes, and our way that we put a student through their clinical and field internship environment, we give them stepping stones to kind of achieve and work through. You go through hospital clinical, where you're getting your first introduction to patient care, or whether it be an EMT class where you're riding on the back of an ambulance and you're there to observe. So, we're giving the students the introduction piece of this. We're allowing them to observe how things work, how the EMS environment works, maybe how the hospital environment and clinic setting works. But nonetheless, we are transitioning them from that observer state to now we're actively engaging with the students. And now the student is working side by side of us to be that functioning team member. So they are aiding in the assessment, they're aiding in the treatment, they're aiding in the decision making of that particular patient, or that particular patient encounter. And then we transition from that team member to now we are pushing that student to be the lead, or being the leader. So now they are giving us instructions. We're requiring them to go in and do, be the first point of contact. We're pushing them to be that lead. So during our field internship with our students, this is kind of the progression that we should be seeing from the students. So, expecting a student to immediately become a team lead and to go in and basically push them out the side door of an ambulance and saying, okay, here's your patient, have at it, it is at times setting the student up for failure. So we kind of have to work through these step-by-step processes in order to ensure that the student is transitioning well to the point that when they become team lead, that they feel comfortable doing that, especially as we move towards the end of their clinical experience. But as preceptors, if we do not facilitate that experience, that learning experience, and that transition, then we have pretty much failed the student. We have failed in ensuring that our profession continues. We have failed in the fact that to ensure that we have high quality people that are in our profession. But nonetheless, ultimately it comes down to how well the patient is going to be taken care of by a student of yours. It's always in the back of my mind throughout the years that I have been doing education of those students that are functioning today. How well are they functioning? How well have they transitioned maybe from that EMT student that I had back in the 90s to maybe a shift supervisor or even an operations director, at this point in time. The fundamentals that I provided them during their time with me as an instructor or preceptor, I hope has made them a better person. So, as trainers, as preceptors, as educators, we're always going to have that connection with everybody that we touch. We're always going to have that piece. So, it's always rewarding when you run into a student years later and they make comments about things that you provided them, or a direction or a learning experience that you had given them throughout their career to make them to where they are now, being successful. So when we continue to think about the understandings of the role of the preceptor, we got to think about exactly what is your main role. What do you what are we as a teaching institution holding you accountable for? What is your agency holding you accountable for as a preceptor? So we have to understand what the roles are. Now, here on this slide, the last bullet of this slide, it says to prepare a competent entry-level paramedic. Well, we can take out that paramedic and we can cross that out and add EMT or advanced EMT, into that statement there. But ideally, what we do want to be able to provide is we do want to provide that entry-level person that can go out in the job force once they get out of our class and get out from our precepting roles and become credentialed at whatever level they become credentialed, and they are competent enough to function in that agency that they are with. That has ultimately been a little bit of a challenge in that the disparity between different teaching institutions have yielded different degree and different levels of providers. Now, what do I mean by that is that, you may have a teaching institution that produces entry-level EMTs based on state standards and can go out and pass a state test, but when they get to the organization, whether it be the county EMS service or a private entity, they are lacking a variety of things, and more recently it's becoming evident that driving has become a problem. that students do not receive adequate enough driver training and driving training during their courses, and that students or new employees are having to reteach and relearn about driving. Now, that becomes a little bit of a catch-22, because unless you have an ambulance at your teaching institution and can provide adequate driver training while the students are in class, insurance pretty much prohibits students from driving company vehicles, such as county ambulances and those kind of things. So, having driver training during their precepting time is unfortunately not something that is commonly done. More times than not, it's actually all the time presently, is that it's more about their clinical experience and taking care of a patient than it actually is driving and operations of a vehicle. Historically speaking, we as educators have kind of left that up to the individual agencies to provide that training to the students, or to their new employees once they become hired. So again, we can take this and we can mark through this paramedic, and we can add pretty much anything that we choose to, but realistically what we want to ensure is that our students are becoming that entry level technician and understanding how that works. So so that's what we're looking for as the role, is when we want to prepare that student. So again, in preparing you to become preceptors and kind of understanding the responsibilities that you are about to undertake, is that we want to provide a learning environment. You can't expect a student that is currently in class to be able to fully and adequately understand how it is to take care of a patient. But we have to educate the students along the way. Things like, in the EMT class, EMTs get about 48 hours of clinical time. They're required to do so many patient assessments and those kind of things. But sometimes maybe even taking blood pressures in the back of an ambulance is a little bit difficult. Manual blood pressures in the classroom is a lot easier than doing it in by back of a moving truck. So we have to ensure that we're giving them that experience and giving them that opportunity to learn. As preceptors, we have to possess good communication skills. Now, there's been a lot of discussion about this regarding, do students need somebody that can communicate well to them, or do students need somebody that basically can show them the way, show them how to do it? But if you can't communicate with people and you can't communicate with a student, you can't be honest, and you can't be at times blunt with them, then sometimes it makes it very difficult for the students to know exactly what it is that they're doing wrong or right. We can all think about those opportunities and those experiences where we have been chastised for the things that we do. We're not commonly praised for the good job that we do. We are commonly criticized for the things that we didn't do or that we did wrong. So there has to be a good balance between the two in order to ensure that the students are receiving that feedback, both critical and positive, because the students aren't going to learn and aren't going to have a change in their behavior unless it's pointed out to them. As preceptors, we have to build upon the student's knowledge. One of the things that we've attempted to do at this training, at this teaching institution, is that make proper notification along the way through documentation when a student has achieved certain goals. So, for example, if a student has started their clinical time and then during their course of the clinical time they have achieved mastery of how to do a humeral IO, then what we will do is we'll make notation in their book the clinical book that they have achieved this particular skill and now can complete this skill while they're at clinical. Otherwise, they would not be permitted to do this particular skill, even though it is part of their requirement. They have not met competency in the classroom prior to going out and starting it and doing such in the field. And that could be with any particular skill. So what we attempt to do is, especially with our advanced level classes, is that we attempt to get most of the necessary skills, at least the high volume skills checked off in the classroom and in the lab, in order to ensure that when they go out to the truck, they are available to be done and completed on live patients. But as preceptors, you need to be able to build upon that knowledge. It's not uncommon for preceptors that are going to be working with students day after day after day to basically test them, to give them their own test, give them homework assignments to do. Things like you run across a case of a patient that has a weird disease or condition. It's not uncommon for the preceptor to instruct the student to go home, research on that particular condition, and come back and report to them. And it's basically just to ensure that we're learning something, the students are moving forward. Things like medication, taking a medication box and pulling out medications every day and testing the students verbally on, okay, pulling out, adenosine and saying, tell me the dose of adenosine and what is it used for, stuff like that. Other things is that, listen to the students. The biggest concern, the biggest thing that I have heard over the years from students and in regarding to preceptors is that the students do not feel comfortable discussing issues with their preceptor, and then it can ultimately go both ways. But as such, you have to listen to the students. You have to kind of listen to what they're thinking in a particular scenario. You kind of have to listen to them on their, if they do something wrong and you identify them doing something wrong, then give them an opportunity to explain and get through. The other thing is that students are going to ask questions, and we encourage students to ask questions. So they have to be able to feel comfortable knowing that there is no such thing as a stupid question. So listening to the students is very important. Provide appropriate steps to patient care. As we go along, as we go through our career, we've kind of adapted or adopted shortcuts. Shortcuts to doing things. We always want to find easier ways to get to the end result. We want to, and you can think of various things that kind of come to mind when you're thinking about shortcuts, and sometimes shortcuts are acceptable, and sometimes shortcuts are acceptable as long as you don't get caught. But as a mentor and a leader, we have to provide that appropriate steps to that care. We have to show them the right way to doing things, and based on your system and based on a standard, and not allowing the students to take those shortcuts. So it could be everything from documentation to drawing up a medication out of an ampule and not using a filter needle, or giving an IM injection in a hurry and not necessarily cleaning it appropriately with an aseptic technique, just using a quick swipe of alcohol prep. I mean, you can kind of think of various things that along the way that I'm sure that you've done, but as a preceptor, it's very important that we ensure that the students are getting the correct knowledge and the correct ways of doing things. We have to demonstrate teamwork with superiors, partners, and other services. The students, as when they're out riding, they're going to be looking for you or looking at you for guidance in every way possible. If you get out of the ambulance on a wreck scene and you don't have your reflective jacket on or your reflective vest on, then the student's going to assume that it's perfectly okay for them to do it as well. If you are responding to a call where you have a fire department or first responder, and your interaction with that service is not not pleasant, or didn't go the way that it should go, then the students ultimately are going to see that and are going to absorb that and going to remember how you treated a particular agency and think that it's okay. You know, so it's very important that you conduct yourself in a professional, polite, courtesy manner, because you have an extra set of eyes that are going to be watching and observing what you do. Other things that you got to do is you got to be knowledgeable. You got to be knowledgeable about what you're doing as a profession. If you need to be the best EMT and the most knowledgeable EMT that you can be. You have to be the best EMT and the best paramedic and the best paramedic that you can be. We certainly, medicine is certainly an ever-changing, dynamic and fluid environment. Things are changing all the time. Practice, and what we do and types of medication and procedures that we do are always changing. So we have to ensure that we are staying up to date with all of the best standards of care and the best clinical practice, because you're going to be asked that why, and not just how. A student's going to ask you, why did this happen to this patient? Why did this piece of equipment fail? And not just how, not just how you do it, but they're going to want to know why. Why are we delivering, an unsynchronized cardioversion, also known as defibrillation, to this patient versus hitting the sync button on the machine and going through that process? So they're going to want to know that. Other things as responsibilities, you're going to need to review the skills level of each student. Currently, here at this teaching institution, we offer 3 levels of training: EMT, advanced EMT, and paramedic. And throughout those levels of training, the students are expected and permitted to do various levels of skills. But it is ultimately your responsibility, as well as a student, to kind of define and to explain exactly what their levels are. And then you should have a fundamental knowledge of exactly what they're permitted to do at that particular level. It is not appropriate for a EMT to be precepting a paramedic student, obviously for obvious reasons. If there is an advanced level call, then it is ultimately being the level of student to preceptor should be adequate, should be the same. Because it's ultimately that level in which the student is trying to achieve. We also have to understand that we want to encourage questions. Test your students. Give them that. Give them that sense that you are trying to make them a better person by eliciting or encouraging them to ask questions, as well as you asking them. Testing them, and at the same time you're providing feedback. Too many times we see preceptor evaluations on students that end up being negative, kind of a negative evaluation. And then when the students are questioned about it, when we bring the students in, we have a conversation about this particular day at their clinical site, they knew nothing about it. It is very, very important that you provide immediate feedback to the students. If they are doing something wrong, then we need to make corrective action, especially if it's at the detriment of the patient or to you or the student. But waiting until the end of the shift, or waiting, or for that matter, writing a feedback down and not having that open-ended discussion with the student is almost inappropriate. If the scenario or the situation is so bad that the student you couldn't even discuss the situation or provide feedback to the student, and the course director or the course lead instructor or the clinical coordinator must be notified of those kinds of things, then additional steps and additional action should be taken. But feedback should be provided to the student after each call. And then sit down with the student during their evaluation and go through their evaluation with them, so they understand and they know areas that they did well in, and then those areas in which they need to improve. our current system and our current feedback evaluations require that the students sign off on their daily evaluation as well. So, that gives you the opportunity to sit down with your student and go through their evaluation and kind of discuss the highlights along the way. So there's no surprises to either the clinical coordinator or especially to the student that weren't immediately discussed during that period. So again, a little bit more on this is providing that learning environment. Our EMS environment is hugely chaotic. No two calls are ever the same. No two patients are ever the same. So our atmosphere is forever changing, and that's what makes this such a great field, is that we don't have that mundane same thing after same thing after same thing. So we have to give them that environment that allows them to learn appropriately. So the environment that we are in is forever changing. So we have to ensure that we are also changing along with the actual environment that we're in. We're actually that learning environment is ultimately changing too. Various things from, here recently they've increased the clinical time for EMT students and required certain things like driver training during EMT classes. So we have to ensure that learning environment is changing, and we have to be able to adapt to it as well. So again, how well do you clearly express yourself and listen to others? This is kind of a big thing. We have to be able to listen. We have to have those listening skills, as well as we have to be able to effectively communicate to our students. We in EMS typically have a type A personality, so we're very vocal and opinionated about things. We're not shy about providing feedback, and we're certainly not shy about expressing what we feel is right or wrong. And it's just because of the environment that we work in. So this goes along with ensuring that our students understand that there's a mutual respect between the two of us. We're going to have a conversation that may not necessarily be pleasant. But you got to understand where me as a preceptor, and I'm expressing this to my student, you got to understand where we're coming from. I'm wanting to ensure that you're going to be great at what you do, and sometimes getting feedback may not necessarily be warm and fuzzy. But on the flip side of things, we have to be able to understand that human beings have feelings, and that we shouldn't go above and beyond to criticize or to judge or to ridicule a student. Other things is that you kind of have to understand that you and your student pretty much form this bond and this link between each other, and there's a trust link. Your student is trusting you to keep them safe, to teach them things, to guide them in the right path. And if there's some reason that is broken, that bond is broken, then it becomes a problem. It really becomes an issue. And one of the biggest areas in which I have seen this happen is when a preceptor goes to another preceptor and discusses a student in a negative light. So in other words, Jane goes over to John and discusses, how well Bob did during his clinical rotation, and basically, talks down and talks bad continuously about Bob. Well, the issue is now is that John is fixing to get Bob to be working with him, and has already formed an opinion, has already become jaded because of the comments that Jane has expressed to John about how Bob was, and it very well could be that Jane was the problem. So how well can you communicate these things? Now, if there's one of the things that I have done in the past, um, working with students and being a preceptor field training officer, is that I will go back into the student's book, and I will review their evaluations. I will sit down with a student beginning of the shift or whatever, and I will ask them, okay, what do we need to work on today? What are you lacking today? Let me see your book, and let me see what your preceptors have said about you along the way, so we know exactly where we're going and how we're going to gear our day. Is it medication? Is it patient assessment? Is it taking lead? Is it lifting and moving the patient and using the stretcher? Whatever the case is, at least that kind of gives me an idea of where we're going to go. And encourage that. Sometimes at the end of a clinical rotation or clinical cycle, especially for paramedic students, those students are really there for time. They've gotten in all their skills that they need to get done, and all they're there is to do time. And unfortunately, that's something that I kind of dislike when that term comes out. I'm only here to get my time in. So at that point in time, a game plan is developed, and no, you're here to improve on your skills. You're here to improve on your abilities, not just to sit in the back of the truck and to get time. So we're going to come up with a game plan, and let's prepare. So we have to be able to clearly express to the student, and listen to them along the way. So, one of the things is you got to think about how knowledgeable you are. When was the last time you opened a textbook? Remember, students are attempting to apply what they've learned in the classroom, not shortcuts or the way you do it. So, when was the last time you actually opened a textbook, you actually read a peer-reviewed journal, you actually did a Con Ed session that wasn't completely boring and you were on your phone the whole time? What are things, kind of think about that. Think about, are you familiar with things? Are you heavily relying on the Hand-Tevi app that's on your telephone to be able to understand what drug dosing for pediatrics are? When's the last time you pulled out the Broslo, or when did you actually practice on the King Vision? When did various things, various things that the students are wanting to learn and absorb, and they're going to be looking for you to know that information. Our paramedic students were provided with with protocol books, so they should be somewhat versed on a protocol book. But when was the last time you actually opened up a protocol book and understood that? Some agencies test their providers annually on protocols. But ultimately, as a preceptor and somebody that's is mentoring other people, they are looking for you for that knowledge. So it's kind of an expectation that you know what that is. Understanding the responsibilities as a preceptor, other things, is listening to the students. When was the last time you truly listened to someone, had their full attention, you didn't have your telephone in your hand, and you had uninterrupted conversation with somebody? These kinds of things sometimes are very difficult when we're working in our field, but ultimately, what's going on at the hospital when you're dropping the patient off and you're making your stretcher. I have a tendency to think that, when I'm making the stretcher up, I'm standing there in front of it, wiping the stretcher down, putting a new clean sheet on the stretcher. That is my time. That is the only thing that I'm doing. I don't have my phone in my hand. I'm not at the Pyxis machine or the inventory or supply cabinet getting supplies out and trying to remember what I used on this particular call or whatever the case is. I am there making my stretcher up, and that seems to be a good time in which I can have a conversation with a student. So, having their full attention, or having you give them your full attention, is really valuable and really important. It really makes the student feel like that you are engaged with them. So, putting that phone away, putting it in your pocket, cutting off the radio, AM/FM radio I'm referring to. Not trying to interact and have a conversation with multiple people, and even going to somewhere that is private, will help and aid in this. Many of our providers smoke, and they have to go to a certain area of a property in order to make that happen, to get their nicotine. And maybe that's the place that you go to have that conversation. But nonetheless, think about when you had that opportunity to provide that feedback to a student when you were uninterrupted. And then ultimately think about it as a student, on a student's perspective. What did that make you feel when someone was constantly interrupting your conversation, or your preceptor, field training officer, supervisor, somebody was completely distracted and not really giving you their full attention? So again, providing appropriate steps to patient care. When appropriate, explain the steps you perform in patient care and why and when it's important to follow and demonstrate this consistent routine. What we mean by that is, kind of this little example that we have here is that, if a patient has hypertension and they have wet lungs and they have dehydration, then it could mean patient's got acute congestive heart failure. And basically, what do we need to do? What we need to think about it is, by removing the fluid from the patient, do we worsen the CHF or do we worsen the dehydration? Those kind of things are things that we need to think about, in our treatment modality. But the students are going to want to know why you did what you did. I can distinctively remember a scenario where I had to modify a bag valve mask in order to administer a nebulizer treatment. The agency that I was with at the time didn't have the appropriate adapters where you could piece the neb chamber and the tubing and stuff to the mask and to the bag itself. So as I'm walking through this process, I'm kind of explaining it to the student about why I'm doing what I'm doing. Little things like, in more recent times, there's been a push for elevating the patient's head to maybe a 30-degree or 20-degree angle on the head of the bed when doing CPR compressions. Why is that being done? Why do we do that? There's other studies that are out there saying, okay, we're doing 30 compressions to 2 ventilations in CPR. It used to be 15 and 2. Why do we switch to 30 and 2? So we kind of have to understand and explain those steps to the students of why we're doing what we do. They're looking for that knowledge. They're looking for that information. Sitting back and scratching their head going, exactly what is happening here and why do they do that, allows the student's mind to wander and may not be exactly correct of what we had intended for the student to know, or intended for us to provide to the student. So again, we think about, this particular cartoon says, Pinky, are you pondering what I'm pondering? And then, he says, I think so, Brain. If we were going to teach critical thinking, won't we need to be capable of critical thinking ourselves? And that's kind of what we're kind of leaning to, is that, if it's very difficult for you to be able to teach and educate somebody if you yourself are not knowledgeable in that particular area. So it's very important that you obtain the information and knowledge in order to be successful in being that preceptor, and knowing your field and knowing medicine is ultimately very important. Teamwork is another big thing. More times than not, I have seen in my career where students are basically shoved out the door and saying, here you go, jump in with both feet. But sometimes that's not appropriate. Sometimes students can't learn that way, will freeze up, and then that kind of creates a mess. So utilizing resources and utilizing students as team members will prepare them to be team leaders. So, interacting with the students, again, more times than not, you're going to be precepting a student as a third person. So have your regular partner on standby, and you function as that partner for that student. Maybe this time you're going to be the lead and your partner is going to assist you, and then the next time your partner student is going to be the lead and you're going to assist them. So making them understand that team dynamic is very important. Most services function 2 people on an ambulance, especially those that are kind of inexperienced won't be permitted to work independently. But we'll give them the opportunity to function as a team, and starting that process in their clinical environment is very important. And it also shows respect. It shows mutual respect. It allows for there to be that interaction between all parties, and as well as other services, to build up that confidence. And that's basically what we're trying to do. So again, we have to understand that questions are a way of seeing. We have to understand that we won't know if we don't ask. The students won't know if they don't ask. So we review skill levels for each student. We encourage the students to ask questions and provide instructional and documented feedback to the student by means of our evaluation. It's very important that comes down to being honest and providing that good, solid feedback to that student, so they know which way they're going. Are they going backwards in their experience, or are they moving forward? So again, most adult learners have not been in the classroom setting for a long time. So what most adult learners are looking for are things that they can immediately apply. Adult students don't want to waste their time. They want to come in, they want to learn something, they want to get out of the classroom, and they want to be able to apply that knowledge immediately. So we kind of have to understand that when we are in our teaching process, and adult learners are going to learn from other people. They're going to see that, okay, well, Jane taught me how to do blood pressure this way, but now John, you're working with John today, and John is teaching you, oh, we don't have to worry about a manual blood pressure, just stick this cuff on him, hit a button. So they do absorb, they retain this kind of information, they're trying to learn. So we have to understand that they want to apply things immediately. Unfortunately, adults, me myself, and it's probably as used too, we try to figure out ways to cut corners, not necessarily to be inappropriate or to do things wrong, but sometimes we're trying to save time. We have limited time with our patients, so if we're back in the back of an ambulance by ourselves, we don't necessarily have time to take a manual blood pressure on every patient. So using an auto cuff is appropriate. We try to do that. Even though it is recommended that we do a manual blood pressure to start with, we have to encourage doing the right thing with the students. Adult learners have outside responsibilities. Most of the people that we work with, especially in our continuing education programs, have outside jobs. They're working full-time and trying to go to school full-time, or at least, it could be up to 20 hours a week, trying to do 12 to 24 hours of clinical time, a week, as well as trying to maintain, a full-time job, trying to raise kids, have a family life and those kind of things. So we kind of have to understand that sometimes our approach to precepting students are, we had to take these things in consideration. Sometimes the people we're going to be precepting and mentor are going to be older than us. They're going to have a certain level of life experience that we may not have. And we kind of have to understand and accept that. We have to kind of nurture that as well. It's kind of a gratifying and rewarding experience when you can learn something from your students. You as a preceptor or as a trainer have that person that can come in and teach you something. That student that you may be working with may be a retired school teacher, or may have worked in the factory for 50, not 50 years, maybe 20 years, and comes with this whole life experience, and we kind of have to nurture that and kind of have to respect that. They're going to feel uncomfortable learning from someone that is younger than them. But again, there has to be a certain degree of mutual respect that goes along with that process. So adult learning styles, again, some are visual learners, auditory learners, and kinetic learners. And what this means is that, to start with, we may have, a visual learner are those that, learn by seeing. Okay, learn by seeing. The auditory learners are just that. They learn by listening. Unfortunately, you are listening to me. You may be seeing me on this particular presentation, but you are listening to the material that I'm providing to you. And then the kinesthetic learner is basically those hands-on people. They have to learn by touching and learning how to do something. It's like a mechanic trying to learn how to rebuild an engine just by listening to someone tell them how to do it. It's virtually impossible. They actually have to sit down there and do it. I mean, it can go for anything for us as well. Learning how to operate a manual stretcher is kind of difficult if you don't actually have the opportunity to put your hands on it. But these are learning styles that kind of we have to be familiar with. Being in EMS, we have a combination of all three of these when we're learning in the classroom, as well as we may have a combination of all three of these when we are on the back of an ambulance. So we kind of have to understand that and recognize that as well. So, for those that see, they are looking for, good at spelling, poor at names, needs quiet study time. These are those people that use visual learning, or they learn by seeing, has to think before giving responses. They like using diagrams and videos, outlines, flashcards, and those kind of things. So, this is just some ideas and some brief characteristics of those people that learn by hearing, reads out loud to itself, good at explanations. They do remember names. Can't keep quiet for very long, uses word associations to kind of memorize things, like sample history. We're going to get a sample history. Or decap BTLS, they use those to associate what they need to do, what they need to remember. Some of those are, follow spoken directions very well, and then they can listen and understand and record lectures and material. Hands-on experience, they learn by doing it. They're typically good at spelling, poor spellers, they have poor handwriting. They can listen to loud music and be successful. They're fidgety. They like particular memory games. They can be involved in more, I guess, rambunctious activities like martial arts or dances, and then studies in very short blocks. They can, we kind of tend to think of these students as being those with attention deficit disorder, without truly being diagnosed, is that, they can have short, brief stints of what they need to learn, and then got to take a break and do something else and come back to it. So, all three of these, we probably can group ourselves into all three of these at one point in time, and probably now, we learn best by using an adaptation of each one of these characters. So what is the difference between a clinical experience, field experience, and field internship? So, how will you know what aspect or what level a particular student's in? Obviously, the best way to find this information out is to ask the student. Ask who you're writing with. Where are you at? The other thing is, check their clinical book. Is their clinical book up to date? And where are they in their clinical completion or their skill completion? Look at the number of hospital. Again, if you're unable to read this because of this video, this down in the bottom corner of this slide, just understand that you're going to look at the number of hours they've completed. If they have completed 24 hours of their 48 hours of mandatory EMT clinical time, you kind of have a good idea that they've seen at least a couple patients, and kind of have an idea about what they're doing. If they are 200 hours or 250 hours into their 300-hour paramedic clinical rotation, then you can pretty much guarantee that they are at the point now that they should be doing team leads and feeling pretty comfortable with their skills. So again, we have to make sure that we are checking in with the student. Ask the student if you have any doubt. Feel free to look at their clinical book. In this particular teaching institution, at least for the temporary meantime, we have moved to a paper book, a paper clinical book that the students will have with them on every clinical rotation they go to. And their clinical book should be up to date. There should not be any missing dates, any missing signatures, or anything at the time in which you would see them. So, check it out. Ask for it. They should have it. If they do not have their clinical book, then they do not need to be doing clinical. They must be sent home. So ensure that is the case. In the past, as well as potentially in the future, we have used and will consider using again electronic format of clinical records, but for the meantime, until that can be sorted out and worked out, then we are going to continue with our paper version of the clinical book. And again, they will have that with them when they arrive at their clinical site. So again, clinical experience, that is a planned, scheduled educational time spent within the hospital setting or clinic. So when we talk about clinical experience, that is referring to the hospital time. Students will observe and practice all aspects of patient care under the direct supervision within a hospital or clinical setting to include specialty care areas. We have explored and will continue to explore sending students to various areas of a hospital or clinic setting. I think that gives them a true clinical experience. I think with the expanded scope of paramedic practice, and paramedics working in plasma centers or health departments or urgent care centers and those kind of places, I think that having students performing or at least having an opportunity to visit those types of clinical settings is important. So, we'll continue to explore those options, but anytime you see clinical experience, that refers to a monitored, secured, controlled environment within a facility. So field experience obviously is a planned, scheduled education time spent on a EMS unit as a team member. Okay, so the students will observe and practice all aspects of patient care under the direct supervision of a preceptor. Now again, this presentation does define that we have a paramedic title here, but ultimately does not have to be a paramedic if the student is riding on a BLS, convalescent or non-emergency ambulance. Just understand that the field experience definition is while they are functioning as a team member within and on the EMS ambulance. Field intern is a planned, scheduled education time spent on an EMS unit as a team lead. Okay, normally this occurs towards the end of their field internship time or their field experience time. Students will be observed and practice all aspects of patient care within supervision, managing their paramedic level, critical thinking, and decision-making skills. Okay, so at this point in time, these are the students that are being team leads and are running the show. Still with their supervision, still with their preceptors available, but that is kind of what we're wanting to see as field internship, making sure that this time occurs towards the end of their field experience time. It really doesn't make sense that the student would be team lead at the paramedic level within the first couple of shifts of their field experience time. They're just not there. They're just not prepared. They're just not ready. They're still in that observation and somewhat functioning as a team member environment. So again, the evaluation process, it is very, very important that the evaluation process be various steps. First is verbal. Talk to the student. Explain to them how well they're doing. Did they do something wrong? Are there areas that they can improve on? Or, ultimately students want positive feedback. They want to know that they did a very good job when it's appropriate. Other evaluation processes is their written evaluations. As a preceptor, you're responsible for doing a daily evaluation on a student and signing off on that particular student. This has to be done daily. It is not appropriate for you to sign several evaluations ahead of time and then fill in the blanks or have the student fill in the blanks. That is completely inappropriate to do so, because that is not adequately evaluating the particular student. Remember that the different types of learners, as an evaluation is a learning tool as well. So, providing them visual feedback, providing them auditory feedback is something that the students would want to have. But, the evaluation process is probably one of the most important key aspects of their clinical experience, is having that appropriate, their correct, and their effective evaluation done after the end of each shift. Now, that doesn't say that you can't provide feedback after every call, which is highly encouraged, but there has to be a written evaluation done at the end of. So make sure the evaluations are informative for anyone who may read it. Currently our evaluation process is on paper. So please make sure that you write to where the students can read the evaluation, as well as the person that is overseeing that, their clinical coordinator, has the ability to review and to adequately interpret your evaluation responses. Acknowledge the student's strong points. Students always want to make sure that they have something that they know they did well. So maybe begin the evaluation process with something that's positive, then lead into something that some area that may need improvement, or something they may have done inappropriate or wrong, and then follow it up or end with something positive as well. So that kind of gives the students the mindset that most adults want, is they want to have that positive feedback and not just something that's critical. Educates the student on their weakness by making suggestions or ways that they can improve. They're always looking for feedback. Now, we kind of have to understand that making suggestions to things should be in line with policy and procedure, as well as protocols. So in other words, if your procedure says that you will document I don't know, a temperature on every patient. So, instead of actually putting a stethoscope on the thermometer in the patient's mouth, or, a tympanic or whatever the case may be, the patient, you acknowledge that you did not take a temperature. Well, it does say in procedure and policy and protocol that the temperature must be taken. So we need to understand that has to be done. So how can we suggest improving? Other things could be grade the student on professionalism. That is a big thing for most agencies. We at the community college have a hard time educating students on what we call soft skills. That's basically skills that they are inherited and have in their genetic makeup. How to be on time, punctual, how to dress appropriately, how to act professional, those kind of things. How, what are their ethics and morals and stuff. It's very difficult for us as an education institution to teach that, but we can provide feedback on how well they interacted with their students. With their patients, how well they dressed. Did they dress appropriately? What were their communications abilities? Did they seem hesitant? Did they stutter? Did they mix their words up? Did they hesitate? Those kinds of things. When we're talking about communication, we can discuss and grade the students on their skill level. If they are paramedic students and they can barely take a manual blood pressure, then we have a problem. You know, students are expected to document their patient encounters, just like you are documenting your patient encounter in your electronic format. You know, they have the ability to document their interaction with their patient on a written format. So, you know, that's another thing that, you know, when they get done with their at the end of their day, maybe that's something that you need to review as well. You know, how well they're using their documentation skills, knowledge level, patient care. How well do they interact with their peers? You know, do they give good reports to the hospital? Do they answer questions appropriately? You know, things like that. There may be areas in which you got to justify, you know, why you scored a patient this way. If you scored a patient as, you know, excellent, you know, that may need some definition. Why? How did the patient provide excellent patient safety? You know, this kind of thing. So one of the things is you know, that I always kind of remember, or try to reiterate and remind each of you about is, you know, you were once a student. You were once there. So, you know, we need to understand, you know, what things did you use to make yourself better during your clinical experience, and what things hurt you, what things happened during your clinical experience that you'll never forget. You know, I have those stories of being involved in precepting at a new agency, had never worked in this particular environment before, and within the first couple calls that I went on, my preceptor was literally cursing at me. Because I didn't do something exactly correct, you know, but understanding that was my second patient that I had seen and not ever worked in this particular clinical environment that I had been in. So, you know, those are the things that, you know, even though that happened probably 15 years ago or so, you know, those are the things that I really keep in the back of my mind that have affected me, and that I use examples when I'm doing preceptor and field training officer training. So kind of recap this, and we're going to kind of finish this up. You know, we've talked about the definition of a preceptor. Kind of think about that again. What is expected of you, and how do you define that? Understand your roles and responsibilities as a preceptor. Know what it means and what adult learners are wanting to get out of the clinical experience. You know, learning and teaching methods that we kind of have to understand when we're working with a student. You know, clinical versus field experience versus internship. Again, we talked about that. And then again, how important the process is for the evaluation tool. Now, the last piece of this is that you will be doing a quick assessment. You'll be doing a quick course assessment to kind of ensure that you have obtained and retained some of the information that we talked about today. And then you will also receive about an hour and a half of professional development, continuing education credit for this particular presentation. If you have any questions, please feel free to reach out to your supervisor, your training officer, or feel free to reach out to your education institution's program director for additional resources on how to be an effective and positive preceptor and role model in the emergency services environment.